Morning, everybody. It is week 9. It is Thursday. It's time for cardiovascular and pulmonary pathology lecture. And here we go. So we left off talking about premature atrial contractions. Remember, that was an ectopic focus that occurred somewhere in the atrial myocardia, which was mischievous. It beat the SA node to the punch, and for that beat, it ran the heart. That's going to cause some abnormal ECG findings. We can see when one of these little pesky things pops up. By the way, with regard to premature atrial contractions, those don't provide rescue beats. We talked about rescue rhythm and rescue beats. When the SA node fails to function, that's always going to be taken over by second or third string with regard to the speed of depolarization. Atrial myocardia typically don't do that. So there's no rescue beats with PACs. You can have PJCs as rescue beats, but not PACs. They're always pesky. They're always troublemakers. Now, these can be a little tricky to find, but not really. If the key is to look for an inconsistent RR interval. Now, we're going to look at another condition today, an important one. Atrial fibrillation also has an inconsistent RR interval, but it has no P wave. And these definitely have P waves. Although they may be upright, they may be downward. But look for that inconsistent RR interval, and that's kind of the key. Specifically, you're going to look for a short one, and we'll do some examples of that here in a minute. With regard to the PR interval, not the RR interval. Did I say PR? RR interval? I think I said that right. It has they typically have a long PR interval or a normal PR interval, so you can tell them. The trouble comes when you have one that occurs near the AV node. If it occurs right next to, in the atrial myocardia, right next to the AV node, then there's going to be probably a short PR interval. But most of the time, even if it occurs, you still get the slowdown portion, so you still should have a little bit of a PR interval, but that's the only kind of fly in the ointment with regard to that rule. And I'll show you. In fact, our first example, I think, has one. So if they occur way in the left atria, they don't use Bachman's bundle, this type of system. So it moves pretty slowly. If it occurs way in the lateral left part of the left atria, you'll get a PR segment that's too long. Okay. I think we meant with this, that should be segment is what we're talking about. Sorry about that. 461 right off the bat. Okay. So note a PR interval. It might have a short PR segment. That's what we're talking about. It could be the interval as well, but really I'm looking at those segments if it occurs close to the AV node. Okay, this is definitely the RR interval we're looking at. So I'll show you in a second. So the P waves may be upright or positive or up pointing, or they may be downward, or they may be negative. Right? Depends where in the atria it occurs. What if it occurs right next door to the SA node? Well, then it's impossible to even tell they exist because it performs just like the SA node in that case. So sometimes you just can't tell they're there. It all depends where they occur in the atria. Normally, they occur right before a normally scheduled P wave. So that's the place to look. In other words, look right after the T wave. Occasionally, rarely, it can occur before the T wave, but usually for our purposes, I won't show you one like that. It's too rare. I'll just show you the ones that occur before the P wave. And it's also important to understand that after the ectopic focus, you know what, too? Let me write down the time here so I have an idea. I don't want to go too long with this. So we start about 9:20. All right, so typically they occur right before the normally scheduled P wave. They could occur after the T wave, but I won't show you one. But it's important to understand that after they occur, the QRS complex and the T wave are completely normal. It's like it's a normal impulse. It's a normal impulse that passes through the AV node. So the ventricles don't know that it's not coming from the SA node. So QRS complex and T wave going to be completely normal. Typically, these things tend to be upright, upward, upgoing, positive, if the ectopic focus is in the right atria. So just remember in GIGU, we said right was wrong. Sleeping on the right side is wrong because we talked about the fundus and how that catches. But it's the opposite here, upright, right. So if an ectopic foci occurs in the right atria, it's going to be upright. So right and right go together. Okay, all right. So study hint, upright equals right. Will be inverted if the ectopic, if it occurs in the left atria, then it's going to be inverted. So if it occurs in the right atria, it'll be upright. If it occurs in the left atria, it will be inverted. Got it? All right, let's check. We're going to do a lot of these today. There'll be a lot of slides today, but there's a lot of these ones. So 44-year-old enters your practice with neck pain and anxiety, feels funny movements in her chest, started after finals, and she can't get rid of it. So you say, we better do an EKG. And so here's limb lead 2, which I could add that to 465. That's limb lead 2. What do you think? Well, we always check the RR interval first. All right, we got a problem, don't we? I mean, we could count these if we had to, but that's the same, that's the same, that's the same, but that's too short, right? No good. So that's a short RR interval. So that means we need to focus in right here. I said focus right after the T wave to see what happens. And first of all, look at the morphology of our P wave. It's about 1 box high, 1 box high. And look at this P wave. So it's 2.5 boxes high. So this is obviously not coming from the SA node. Also, the PR segment is shorter than this one. But you can just tell by the morphology that's not right. And the rule is, now where's it coming from? Well, if it's upright, it's right. Right is right. So it's coming somewhere from the right atria. So this is a PAC. It's a premature atrial complex that we're seeing, caused by a premature or an ectopic foci in the right atria. Right? Simple as that. Right? Everything I just said there. So you can read through it. And also note, we have a normal QRS complex and a normal T wave. That might have well been generated from the SA node. This doesn't care. It's exactly the same. The height is exactly, the voltage is exactly the same. The width is exactly the same. Yeah, so it's normal. It's a run-of-the-mill PAC. Probably no big deal, especially if it doesn't happen very often. So maybe it came like this. Maybe it was right here in the middle of the atria. Limb lead 2 is watching, so the atrial wave is heading right for it. So it draws a positive upright wave. Good. Diagnosis, premature atrial contraction coming from, or complex, coming from the right atria. The shortness of the SA, or the shortness of the PR segment indicates that it was fairly close. Is probably more like, yeah, I guess that would work. It wasn't up here. Right? It wasn't up here. If it was up here, it would take quite a while for it to get down to here. So you would get a longer PR segment. Oh yeah, I was right. Those are all correct. Because the PR interval should be the same. The PR segment will be, just the depolarization is slower. So those slides were actually right. So it is a PR segment, or PR interval, because the P wave is going to be bigger and it's going to take more time because it's not using the normal pathways to spread its depolarization through the atria. And some of it's going to go over this way. So instead of a little short P wave, you're going to have a P wave that is bigger voltage. And PR interval in general will be longer because it takes more time to get across here. Okay, so I was okay on that. All right, let's do another one. These are fun. Here's an asymptomatic 64-year-old comes in your office for a routine pre-employment, kind of old to be starting employment, but in this day and age, it's probably not unusual. He gives no history of heart disease, says he's in excellent health. All right, so you run a rhythm, or you run a tracing on him, and here's what you find. What do you see? There's a couple things. First thing we do, let's check the rhythm. And while you're checking the rhythm, we can't really even count because this jumps right out. This RR segment here, or RR interval, is messed up, right? This is much longer. This is short, and this is back to that. I mean, we could count these. Let's count them. 5, 10, 15, 25, like 28-ish. 5, 10, 15, 20, 25. Did I mess up? 5, 10, 15, 20, 25, 5, 10, 15, 20, 25, 30. Oh, okay. 35. Now, I didn't put this in here, but there is, I guess I should put this in here next time, but I won't test you on it. So another way you can tell, kind of hard to eyeball, but after a PAC, a PAC occurs, you get what's called a compensatory pause. So the following RR interval will be longer than the normal RR intervals. It's called a compensatory pause. It's probably a good one to put in. Comp pause for next quarter. Right. If I were to count another one out, it would go back to this same pattern, but that's a nice example. How is the heart rate, by the way? Well, that would be 300, 150, 100. It's not a tachycardia. 75, 60, 50. So it's running what, about 50? I don't know, 55 maybe, something like that. But now let's look at the morphology. Tell me more about this. Well, let's look at the normal P wave. Okay, it's about one little box high. Now this one obviously is too wide, so that means it has a little traveling time across the atria, but it's inverted, right? So where do you think it's coming from? Well, right is upright, so it must be coming from the left atria somewhere, and it's taking quite a while to get across here. In fact, 3x5 rule, 1, 2, 3. Let's see, let me try 1, 2, 3, 4. So yeah, it's about 4 little boxes here, about 16 seconds. So it's still considered normal, but yeah. But anyway, so we have it's a PAC, a premature atrial complex is seen on EKG, which is caused a premature atrial contraction of the heart, and we can tell it's coming from the left ventricle. And yeah, the other thing some of you might be looking at is the spike in these T waves. Okay, I think I have some slides on those coming. You have to be careful with those because we talked about an elevated ST segment as a sign of myocardial infarction or acute pericarditis, but there is an EKG finding that precedes that, and that's called a peaked T wave. The trouble with this is, if it was a myocardial infarction, typically they're up higher than this. They're more than 50% of the height. So I wouldn't suspect this to be a pre-heart attack happening. Another problem is hyperkalemia can also cause peaked T waves. But remember the law for my testing. If it's not on the slide, I'm not going to test you on it. All right, so I think we got everything I said here. And then how do you know that's not a because we looked at premature junctional complexes are always inverted. How do we know that is not a premature junctional complex? Because those are always upright. Is that true? Yeah, how do we know? Because of the PR segment. If it was a PJC, there would be no segment because these are occurring within the AV node itself. So the bypass slowdown portion is non-existent. So we know it's not a PJC because of that PR segment. Are we good? All right, so and maybe it's coming right here. So limb lead 1 and 2 would see it going away, and it's not using Bachman's bundle or any of the intranodal pathways, so it's taking some time to reach the AV node. All right, that's all we'll say about those. Now let's get into supraventricular tachycardias. This is an important area. This is an umbrella category or a main category, just like when we talked about arterial sclerosis. Has 3 subcategories: atherosclerosis, Monkberg's mediosclerosis, arteriolosclerosis. Remember those? Same kind of deal. These are all supraventricular tachycardias. Tachycardia means the heart rate is going over 100 beats per minute, usually greater than 120. It's another little thing to fix. Put 120 beats per minute. Supraventricular means it's above the ventricles. In other words, the ventricle myocardium is not responsible for the heart running this fast. The problem is up in the atria or the junctional region. These are all supraventricular tachycardias. Sometimes they're called paroxysmal supraventricular tachycardias. Instead of SVT, they're called PSVT. Why? Because sometimes they start completely out of the blue and they stop. You can never predict when they stop. They may just stop out of the blue as well. So they're unpredictable. That means paroxysmal when they're unpredictable. What are the general causes of SVTs? Well, there's three main, really the pathophysiological. We'll look at some of the risk factors. But the pathology, there's really 3 of them. One could be a really fast ectopic foci, depolarizing twice as fast as the SA node. And it could be, and it goes and goes and goes. It goes for maybe half hour, maybe a day, maybe a week, maybe it goes forever. Another is a gang of ectopic foci, where you don't have one, but you have maybe 5 of them going in different parts of the atria. Maybe one's even in the junctional region. And then the next one, this is the phenomenon of re-entry circuits or re-entrant circuits. This word is often used, re-entrant, but it means re-entry. Sometimes it's called a circus movement. Sometimes it's called a re-entry circus. So these words can all be kind of flipped around. Typically, I just call it a re-entry circuit. All right, so we're going to look at that, how a vicious racetrack of current can get set up in the atria, swirling really, really fast. So we'll look at that. Let's meet them. I always ask a question. This is probably 80% probability, 90% probability that this will be a test question. Who are those supraventricular tachycardias? Well, and I used to have slides on all of these, but I have been trying to cut this down. We just don't have time in this class to show you everything. But sinus tachycardia means that the SA node itself is running too fast, and that can happen. We'll talk about EAT, ectopic atrial tachycardia. That means the ectopic foci is in the atria somewhere. We'll talk, I just cut, last quarter, I cut atrial flutter out. Atrial flutter often leads to atrial fibrillation, and this is the big one here. Atrial flutter can be dangerous as well, but I do have a YouTube video on atrial flutter, so you can go check that out if you'd like. Still board stuff here. Atrial flutter is pretty straightforward. This one's a little harder to understand. Atrial fibrillation, of course, is the big one. We have a junctional tachycardia we'll talk about. Probably should cut that out eventually. And then AVRT and AVNRT. We won't get to those until Monday, or when's our next meeting, Tuesday. So these are all the supraventricular tachycardias. Let's start with a junctional tachycardia. So this one it doesn't always mean there's structural heart disease, but if there's not a reason, like if the patient went out drinking on a drinking binge because they just got on vacation, then it's most likely not a structural heart problem. Drinking can cause probably any one of these types of arrhythmias that makes the heart really, really twitchy. Same with hyperkalemia, can make the heart twitchy and prone to spark any of these things. But if there's no reason for it, then you definitely want to refer to a cardiologist or electrophysiologist. As a chiropractor, if you run across any of these, you refer to a cardiologist. This is not our specialty. I'm just trying to, and even with this class, I wouldn't be comfortable with you guys setting this up in your office without further instruction. But I always use my daughter's an RN, and she has a pretty good understanding of all this stuff. They go over this quite a bit in nursing school, and she's done quite well on my tests. Just to see where we're at. But you definitely you'll have a good understanding of this stuff. I think you'd probably need more instruction before you would try this on your own. Be happy to teach a class on that. Anyway, so always refer, as a chiropractor, physical therapist, refer these to a cardiology, even a primary doc, a healthcare provider. If you're going to be just a family doc or an internal medicine specialist, this is not your realm. You should refer this to a cardiologist. That's let them deal with it, because there are rare instances where it could indicate something else going on with the heart. So a junctional tachycardia, these are not the Sully guy, right? The hero. These are mischievous. So the question could say it's caused by enhanced autorhythmicity of the AV node. That's a fancy word for saying a really mischievous ectopic foci somewhere in the junctional region, or usually in the AV node, the proximal or distal approach tracts. All right. So this ectopic foci is going twice as fast as the AV node. It's depolarizing so fast, the AV node doesn't do anything anymore, or the SA node doesn't do anything. The AV node is depolarizing twice as fast as the SA node. So you get a heart going about 120 beats per minute or so unusual. So these are not heroes. It could come from the bundle of His, right? We talked about PJCs. It could be any one of those, and you get the same type of morphology of the P wave. Now, there are some more serious causes that you have to worry about. So it could indicate myocardial ischemia. It could be a pre-heart attack getting ready to occur, and it's presenting as a junctional tachycardia or a supraventricular tachycardia for that matter. Digoxin toxicity. Grandpa and grandma take too much digoxin. It can make the heart twitchy, and you could go into this. Kind of ironic because digoxin sometimes is used to treat cardiomyopathy and arrhythmias, but you don't want to take too much of it. Pulmonary hypertension caused by COPD, where the right atria is all stretched out, damaged. When it gets stretched out and damaged, it gets twitchy and jumpy, and it's prone to kind of throw an ectopic foci or two. And in this case, it's the ectopic foci is going really fast. Rheumatic carditis, we're not going to get into that. It happens, but it's more rare. Hyperkalemia. Hypercalcemia can also do it. Not as common as hyperkalemia. We don't talk much about hypercalcemia. It's pretty unusual. ECG findings, well, it's really just it's slow. It's one of the slower supraventricular tachycardias. And never say never, because people get anxious, and when they get anxious, their rate of ventricular contraction can go up just from the anxiety. But usually it's about 120 beats per minute. There's another one I hope to get to by Monday. If I don't, I do have YouTube videos of AV NRT up that you can watch. But I want to get to AV NRT if possible. This is the most common cause of supraventricular tachycardia, and it looks really similar to a junctional tachycardia. These guys are twins, and that's the only reason I'm keeping junctional tachycardia in, because they look so much alike. One difference is that not always, but on average, AV-NRT runs a little bit faster. According to Garcia, it runs about 140, 150, maybe 160, but on average, we always say 140, 150 beats per minute, whereas a junctional tachycardia runs about 120 beats per minute. But that's not a heck of a lot of difference, so it's really hard to tell these two apart. The rhythm of the heart is normal, so there will be no premature complexes. The RR intervals will be normal. Occasionally, if the rhythm gets variable and you start getting some different length RR intervals, it doesn't happen that often. But if it does, it's really hard to tell apart from atrial fibrillation, except in atrial fibrillation, there's no P wave. So that would be the way to tell that apart. No P wave. I should probably add that in, although we're coming to that. You can tell that apart, but no P wave. The QRS complex duration is typically normal. It is about between 3 and 4 seconds. Most authors use 0.10 seconds. It should be less than the normal width of the QRS complex. Some actually go to 0.12, which is 4 little boxes, or sorry, with 3 little boxes. So 2.5 little boxes, some authors. What about the P wave? It's going to be inverted, right? Because the ectopic foci is in the junctional region. That means the P wave is always inverted, right? So it could come immediately before, might be hidden by, might come after the QRS complex, just like when we talked about PJC, same kind of deal there. If the P waves are seen after the QRS complex, where does that mean the ectopic focus if you see a P wave coming after the QRS complex? No, not in the AV node. This comes later. Bundle of His. It's got to be coming from the bundle of His. But especially if it's in the proximal portion of the bundle of His, you get a slurring of the S wave. Instead of, remember, let's see, what color should we use? Remember the QRS, so here's the Q, there's the R. We're making these with straight lines. There's the down limb, there's the S wave, there's the S wave. But people, if it occurs in the bundle of His, you get Q wave, there's the isoelectric line, R wave, and then the S waves can start to look like that, exaggeration. That's called a slurring of the S. I got a better picture than this, but that's a slurring of the S wave. Unfortunately, that can also be caused with AV NRT as well. So you can see those are, there's probably one more, I can't remember which one. There's another one that can slur the S wave, but not common. So slurring of the S wave, you think a junctional tachycardia, or you think AV NRT. All right. Sometimes they call that a R prime wave, and when you see a slurred S wave, they just call it a R prime wave. I'm not going to go into that because it's too confusing. I'm just going to call them slurred S waves, or if I name it, you can call it a pseudo S wave because it's slurred. So as I said, differential diagnosis, 50% of the in 50% of the cases, another supraventricular tachycardia called AV NRT can also have these slurred S waves, these pseudo waves. So AV NRT can be a definite cause. But remember the difference again. Tachycardia is typically 140, 150 with AV NRT. It's 120 with a junctional tachycardia. Or with a, junctional tachycardia. All right, so here's a cartoon of one. So this is kind of what it'll look like. It's a little bit harder to see, but you can look, there's two lines here. There's one straight edge, goes to here, and then you have to get a second straight edge. So it should be made by one straight edge, and because it's not, that's a pseudo R wave, or a slurred R wave. Or sorry, S wave. Oh, gee, did I say S? That's slurred S wave. S for slur, right? S for slur. All right, everything I said, the down limb of the R wave should run straight into the down limb of the S wave, but it doesn't. There's an extra bend in it, so that's a slurred S wave. Let's do another one. 25-year-old college student into practice, complaining of some dizziness, pre-syncope, anxiety, and not feeling good. Hard night of drinking at a frat party a couple days ago. Thinks he might have some pain in his chest. Run a rhythm strip. What do you think? All right, well, let's analyze it. So the RR intervals, I don't think I need to measure them, but they look pretty darn similar to me. So, and what's the speed of this? Do we have one close? This one's pretty close. So there, that would be, if the other R wave was here, that'd be 300. That would be 150. That would be 100. So it's definitely a tachycardia. It's over 100. 150 is here, so it's closer to 150 than it is 100. It's probably like 140. So they got a pretty good tachycardia going here. Now let's analyze it a little more. Is there a P wave? Well, we find the T wave, and yeah, that's a pretty big T wave. But again, if you're thinking about heart, you're not going to think of a heart attack in a 25-year-old, and it's got to be more than half the height of the QRS complex. So I'm not really worried. It's not sharply peaked either. But it's possible. I mean, it's a little peakish looking. So you think maybe hyperkalemia, but probably not. But the big thing here that we're worried about right now is this. So now the question is, there's two possible causes of this tachycardia. That's an inverted P wave. What are two conditions that can invert the P wave? Well, a left-sided ectopic focus coming from the left atria. That's EAT, right? What's the other one? Junctional tachycardia. Right? They can both invert the P wave. So now what's the difference? Well, with EAT, with atrial tachycardia, they have usually a normal PR segment and PR interval. And there is no PR segment. So that's right. It's a junctional tachycardia. In fact, what part of the junctional region is it coming from? proximal portion, or maybe the approach tracks. All right, so that's the exact deal with that. Everything I said came out to be 125 beats per minute. Probably looks more like 130, but I did the 1500 millimeter rule to make sure. Yeah, so everything else I already explained. This is a classic junctional tachycardia from alcohol toxicity. Are we good? Let's do another one. 42-year-old man. And by the way, these, you can bet there'll be a lot of these rhythm strips up on your final exam, so you better get used to looking at these things. I think I had about 10 of them last time, or 5 to 10 of them. There's a bunch of them, so make sure you won't pass the test if you don't know anything about this. All right, 42-year-old man in good health comes into your 10th after rise. Oh, tent. Oh, geez, I just made this one today. It should be tent. After a run, or after a race. So it comes into your tent after a race. He couldn't catch his breath after this 4-mile race. So first thing we look, how's the RR intervals look? Well, let's see. Boom, boom. They just eyeballing it, it looks fine. But what's the speed of it? Let's use this one, it's pretty close. That would be 300. It ain't going 300. That would be 150. That would be 100. It's definitely up in that 125-ish region, 130 region. So we got a good tachycardia. Not crazy one, but got an uncomfortable tachycardia. Moderately uncomfortable. Now, where's the P wave? Don't see it. You see it anywhere? And that's not it there. Got to be more than that. So where is it? Right there. It's hidden. Right? It's hidden behind the QRS complex. So what is this? It's a junctional tachycardia. Where's the ectopic foci located? Proximal AV node. See how that works? Pretty simple. Another one. Oh, wow, we're doing a lot of cases today. 42-year-old comes in, finishes the Boston Marathon, but had to go into the ER 4 hours later because his heart wouldn't calm down. Here's the tracing from the ER. What do you think? Something funky going on there after the QRS complex. Yep, let's blow that up and take a look at it. What's the heart rate, too, while we're here? Well, let's just grab this one. That would be 300. That would be 150. This one's pretty high. This is over 120, 125. This is probably 130-ish, and 130 somewhere. Where's the P wave? I don't see it here. Oh, we got something funky going on here. There it is, right there. Right? So we got a P wave. Now this one didn't really, I mean, you could call this, could you call that a pseudo S wave? I mean, it's not really slurring that. It's come so late, it's formed its own wave there. So I really wouldn't call it a pseudo S wave. It's its own entity. And where's it coming from? Good. Bundle of Hess. It's got to be coming from the bundle of Hess. All right, everything I said. Yeah, we're good. All right, what do you do for treatment? And we'll get into treatment more on Monday when we talk about the treatment for atrial fibrillation. But for all these supraventricular tachycardias, it's kind of the same hierarchy of treatment. First thing you do, the goal is to slow down the rate of ventricular contraction. So you can try carotid massage, which we'll talk about more on Monday. Not recommended. It's only recommended to do this in the emergency room. There is a paper from the New England Journal of Medicine that came out, I want to say 2016, that showed that by doing carotid massage, there is a chance that you could spark a ventricular tachycardia and the patient could die. So because of this article, which lawyers, of course, would use against you if you did carotid massage on a patient, and they died they went into ventricular tachycardia, ventricular fibrillation, and died, they would definitely use that because New England Journal of Medicine, I mean, it doesn't get any better than that. That's one of the top, that and the Lancet are the top journals in the world. So don't recommend doing carotid massage unless you're a trained EMT and have a defibrillation kit there in your office. If you're a chiropractor, I just wouldn't do it. Send them to the ER, let them do it where if it does. And I mean, it's probably like Marfan syndrome. They didn't give a prevalence in the paper, but it's rare, but it can happen. So in the ER, they can try carotid massage, which sometimes it works pretty good to slow down the rate. It causes an increase in decremental conduction and can slow it down. If that doesn't work, they could use the old reliable adenosine to slow the tachycardia, and that works pretty darn good. In fact, it almost always works. But it's a horrible experience. People who have had it say it's like a near-death experience. It actually stops the heart for a second. And with these slower tachycardias, you can just monitor them. Usually they kind of peter out after a while and go back to normal rhythm. But no matter what you do, you got to send this patient to a cardiologist. They have to be worked up because we said this is associated with disease of the heart. If it doesn't slow down or if it goes into this supraventricular tachycardia often, you can try a beta blocker regimen, which kind of settles everything down. For stubborn cases, propranolone can be tried, sotalolone can be tried, and if it doesn't work, you send them to the cath lab. If they can map it and find who the focus, if it's just one ectopic foci, they can destroy it. Go in there very carefully with I wouldn't do that. I do this at Stanford or UCSF or UCLA or some big school like that, and see if they can knock it out, and that could completely solve the problem. All right, let's go to EAT, ectopic atrial tachycardia. So this one has, Mr. Spock is even surprised at all the AKAs for this, but it's called automatic ectopic atrial tachycardia, automatic atrial tachycardia, paroxysmal atrial tachycardia, interatrial, reentrant, supraventricular tachycardia, focal atrial tachycardia. How about just atrial tachycardia, for goodness sakes? That's all it is. Nevertheless, the authors have all went out on their little word crusades. I'm just going to call it EAT, ectopic atrial tachycardia. Very similar story to a junctional tachycardia. But the only difference is this tachycardia arises from the atria, where a junctional tachycardia arises from the junctional area. Simple as that. There are two main kind of pathophysiologic causes of this. One is a single really fast ectopic foci, which is beating the heart, running the heart really fast somewhere in the atria. That's more amenable to zapping it, to getting rid of it if it really bothers you. But then it can also be from a micro reentry circuit. Macro reentry circuit is a much bigger racetrack. That's an atrial flutter. Go see my YouTube video. Micro circuits can be a little more tricky to ablate, but it's still doable. So it's either a single ectopic foci, a wild hair, a mischievous cardiac cell, or it could be this weird micro reentry circuit which is caused by some type of injury. So this is an important slide, important concept of how this micro, and it's very similar to how a macro reentry circuit is set up. But so step one is the SA node sparks an action potential. That was a terrible action potential. Still terrible action. Trying to make a lightning bolt. There we go. Action potential. All right. And so we have some waves of depolarization. I mean, some are going over Bachmann's bundle this way. But a couple of them are heading down the intranodal pathways, and they're going to hit the SA node. Or, I'm sorry, the AV node would be down here. That's where their target is. And then there's, of course, this little stubby approach track. Maybe he's got 2 approach tracks. But yeah, that's where it's going. But on the way in the intraatrial nodal pathway, or maybe it's just the myocardium, somewhere we've had an ischemic event which caused a little patch of heart tissue to be damaged. It still works. It can conduct impulse, but it's damaged and it doesn't do it very good. So that's one criteria. You have to have a damaged patch. Damaged patch of cardiac tissue. Number 2 is just the normal morphology of your cardiac atrial cells, because everybody has a different type of cardiac cell. Some can repolarize really quick. Some don't repolarize very quick. Some are like average. So these cells also are very quick repolarizing cells, the neighbor cells, and it's the cell itself. It's a quick repolarizer. And so in this situation, here's what happens. So we have 2 currents side by side. One hits this dead, dying area, and the current is slowed way down. So it can't zip right through this. There's another heart cell here. Chou just goes around it, and it comes out over in this region, and then it continues on. But it does give it a little bit of a delay as it bounces around the outside of this. So what this current goes on, hits the AV node, and boom, the heart is all refractory. It's all going through repolarization, so nothing can happen. But because it's a quick repolarizer, this is already gone. This tissue has now come back to life, and it can accept another action potential, right? So by the time this pokey current finally pops out, it can also go this way, which it does, but it also looks to go other ways. And if these cells right here, I mean, there's cells everywhere, right? If these myocardial cells have been repolarized, part of the current goes backwards. And when it comes to the top of this slowdown area, I mean, it spurts out all directions again. But part of it can go, because it's a fast repolarizer, it can go back down the slowpoke again. And when I say slowpoke, I mean it can run the heart 180 beats per minute. Some heart tissue can run it at 500 beats per minute. Okay, but this is a kind of a slowpoke. So you get a racetrack anywhere from 120 to 180 beats per minute. And this is throwing off action potentials. So 180 beats per minute worth are hitting the AV node. By this spinning reentrant system that was set up, it's also throwing action potentials backwards and knocking the AV node out. The AV node doesn't have a chance to restart. So this has become the new SA node, so to speak. But it's not an SA node, it's atrial tissue. So that's a reentrant tachycardia in a way. But because it's pure atrial tissue, we just call it's still part of EAT, ectopic atrial tachycardia. But this one's caused by a micro reentry circuit, which cardiac electrophysiologists can find these things. All right, so play that back. Is there good YouTube? I never really saw. Maybe I haven't looked in a while. Maybe somebody's explaining it with nice animations, but that's the story with that. All right. So how common are these? If you go to the hospital with your heart racing, what's the chances it'll be an EAT, ectopic atrial tachycardia? About 15 out of 100. So it's usually not. It's usually AV-NRT, and then AV-RT are the two big ones. Has a higher prevalence in children, goes up to 30-40% in children. This one is typically a little faster than junctional tachycardia. It can run the heart, and AVRT. It can run the heart usually around 150, similar to AVNRT actually. These ectopic foci typically love to pop up in the left atria. So therefore, which way are the P waves going to be? Well, right is upright, so left, yeah, so they're going to be inverted. Okay, so they'll be inverted. These also like to pop up in the orifices for the pulmonary veins in the left atrium. That's one of their favorite spots. And that'll still create everything that we see here. But that is one spot the electrophysiologists do like to look for. P waves will be inverted. There's the pulmonary orifices, right? EKG findings. So the ratio of P waves to QRS complexes will still be 1-to-1, just like most of them. The RR intervals will be the same. QRS complex will be normal because the signals are using the AV node, so that's all going to be normal. P wave is typically inverted and upside down, as we said, because it starts in the left atrium. If it does start in the right atrium, then it's going to be upright. The P wave will never be hidden by a QRS complex. If it's hidden by the QRS complex, then it's a junctional tachycardia. Okay, PR interval will be normal. Maybe a little bit longer. You'll definitely be able to see a PR segment. In junctional tachycardias, you don't see a PR segment, and the PR interval is short. Let's do another one. 25-year-old college student comes in to the ER, palpitations, anxiety, pre-syncope after midterm exam week, several all-nighters, lots of caffeine. She can't get her heart to calm down. Let's see what we got here. I should be getting pretty good at this. Perfect one to test the what is the heart rate. There's 300, there's 150. Definitely a tachycardia closer to the 100, so it's probably 120-ish, maybe 150, 120-ish. Now let's see what else is going. It looks like the intervals are normal. There's the T wave. How's the P wave? Okay, the same morphology each time. You can look at the P wave to make sure it has the same morphology, so it's coming from the same ectopic foci. There's definitely a PR segment, right, on these? So can this be a junctional tachycardia? No, there would be no PR segment. So this is a EAT, ectopic atrial tachycardia. Where's it coming from? Right is downward facing. Right is reverse. So yeah, from the right atria somewhere. Right, everything I said about 115. Yep, that's kind of a fluke, that T wave. We've talked about that because the other ones are fine. Well, maybe they're not fine. That's peaked. Yeah, maybe I'll take that back. That one's, I'd have to see the whole tracing, but it makes you think maybe a little hyperkalemia going on there. Certainly in this age, you wouldn't expect a myocardial infarction. The T wave, the peak T wave would have to be about that big. Then we'd be myocardial infarction until proven otherwise. Very early sign of a myocardial infarction. Then the Q wave would come next. Q waves get huge, and then the elevated ST segment. Yeah, peak wave is a fluke. If they were constant, though, you could rule out hyperkalemia on this one. Probably coming from over here, right? Camera sees it going well away, and it takes a while to get to the, so it's going to have a PR interval will be normal, or maybe even a little bigger than normal. How about this one? 6-year-old female enters the practice with dyspnea, funny feelings in her chest, recently lost her husband. She hasn't been sleeping. She's obviously stressed. All right, let's go through our, give you a second or pause it. Try to figure this out without looking. Okay. Let's count it. 300, 150, 100, so it's over 100. It's probably 120-ish, something like that. Let's look for that P wave. T wave, how's that T wave looking? That's a little pointy looking. So, and it's almost half. I don't think it's quite big enough, but I would, because of her age, makes me wonder a little bit if this is a pre-myocardial infarction. I would like to see that up a little bit higher maybe. But you can run some troponin, see what the troponin levels are, just to be sure. Is she having chest pain? No, funny feelings, but nevertheless, getting a little worrisome there. What about the T wave? The P wave? Yeah, there's no PR segment. It's upside down. There's the P wave. There's no PR segment. This has got to be a junctional tachycardia. Got it? See another problem? Yeah, we talked about the P waves. It's peaked. It's tall, even taller than the other leads, which I didn't show you. Okay, so that's going to make you think myocardial infarction or hyperkalemia. So, yeah, it could be either of those, as we talked about. In fact, this patient, a little more about her, she was on stage 4 kidney failure, and she missed 3 dialysis sessions. So, in fact, she did have a potassium buildup in the blood. She did have hyperkalemia, and so those were ultimately thought to be associated with the hyperkalemia. And again, it could be one of the first signs of myocardial infarction, so probably run troponin levels just to be safe. Tachycardia rule: anytime you have a tachycardia and EKG, think it's atrial in origin if you meet these conditions. P wave is inverted. There's a normal or prolonged PR interval, and the atria to ventricular conduction ratio is 1:1. For every what does that mean? For every P wave, there is a QRS complex. Atrial fib, how are we doing on time? Yeah, I really want to go start this at least. Atrial fib, we see the commercials. This is a pretty big one, right? It is a very common cause of supraventricular tachycardia. It's not the most common, but in the elderly, it's getting close. This does not normally occur in normal hearts. You worry about something's wrong with the heart. You got to know these three. This is the only time I could talk a lot more about these, but you got to know these three right here because we haven't talked much about disease of the heart itself. But here's 3 big diseases. These are cardiomyopathy, means that the heart is dying. It's losing function. It's losing the ability to pump blood. And now, if we put an adjective before, it tells you what the dying heart is from. If you just use the word the patient has cardiomyopathy, it doesn't really tell you much because that's the parent category. So hypertrophic cardiomyopathy means the left ventricle is big. It means we have a left axis deviation on the EKG. What is it caused from? It's caused from the left ventricle having to contract too hard to perfuse the body. In other words, to keep the blood flowing out of the heart or flowing at adequate pressure. So what is that caused from? Aortic stenosis is notorious for causing this. You can, just like hypertension, you can go for years and not figure that out. But you can ruin your heart from that because if the aortic valve doesn't let much blood out, you got to use more pressure, more push to make sure that you do get more blood coming out of that little hole. And so the left ventricle gets really overworked. Same thing from hypertension, which is caused maybe by arterial sclerosis. And again, the heart has to push harder to get the blood to flow through those blockages, and that can wear out the heart as well. So left ventricle is overworked and it's dying. So chronic hypertension, what causes chronic hypertension? Probably arterial sclerosis. There's other causes, right? There's all sorts. We talked all about primary and secondary hypertensions. But what about ischemic cardiomyopathy? What means the heart is dying? Why? Because ischemia. Why would the heart becoming ischemic? The usual reason is coronary artery disease, right? Coronary artery disease, which I could have added that in there. Maybe I'll make a note of that. 514 CAD. What is CAD? Well, it's the arteries are clogged up with atherosclerosis, and therefore the heart in general just doesn't get good perfusion, and it's slowly dying because of that. It's becoming ischemic and not working because it's never has enough food, never has enough oxygen. Another one is restrictive cardiomyopathy. We talked a little bit about that, how it can be caused by, it could cause Kussmaul's sign, right? That's where we talked about that. It's usually from amyloidosis is the big cause of that, but it scars up the myocardium of the heart. Oh, no, we talked about restrictive pericarditis. I don't think we talked about, I think they took those slides out on restrictive cardiomyopathy. But amyloidosis is a disease which deposits scar tissue in tissue, including the heart and liver, and it makes the heart really muscular and stiff, and it can't pump blood very good because of that. And restrictive cardiomyopathy can turn around and become ischemic cardiomyopathy because of its lack of output. And plus, lack of output, you're going to turn on the R2A system, and then we know about angiotensin II and aldosterone can have negative effects on the heart as well. What's one of the big dangers of atrial fibrillation? Remember we saw this? Bombs away, there's an embolism. And so atrial fibrillation runs the darn heart at 550 beats per minute, and that increases the risk for atrial thrombus to occur because that blood is really not moving very good. It's kind of stagnant and swirling around meaninglessly, and it can form clots in there, especially if you're thrombophiliac. So it's the number one cause of disabling stroke or fatal stroke in America. Let me say that again. Atrial fibrillation is the number one cause of disabling stroke or fatal stroke in this country. And it increases the risk of having a stroke 5 times greater than the average bear would have. Why is that? Quivering left atrium is a thrombus factory, and a piece can break off and cause an embolism. And now with an arterial embolism, it's Russian roulette. Does it go up to the brain and cause a stroke? Does it go in the coronary artery and cause a widowmaker heart attack? Does it go down into the superior mesenteric vein and knock out your intestine? It's very, very dangerous. So it also is associated with a risk of mortality from all cardiovascular disease events, even if you can't seem to figure out why, but it's just not a good condition to have. Is it hereditary? There is a hereditary connection. There's some genes that may be involved in this, but I'm not going to go down that pathway. What's the prevalence of this in the United States? 2% of people. 2% of people under the age of 65. If you go over the age of 65, it almost approaches 10%. 1 in 10 people, or 1 in 9 people. So that's a lot of people battle this thing. African Americans are at lower risk than white people are. Females tend to be more affected than males, probably because females live longer. What are the causes of atrial fibrillation? There's 2 big causes. You can have a gang of ectopic foci, so not just one really fast firing ectopic foci in the atria, a gang of them, 5, 10, 15 of them. Or you can have a gang of reentry circuits, and they may be little ones like the one I just drew to you. Maybe there's 10 of those going on. Maybe there's some big macro reentry circuits where you have a big piece of tissue that is semi-dead and there's a delay. You can set up a huge racetrack around that. So it's difficult to treat this. The success rate is not the greatest because if there's multiple ectopic foci, I mean, what are you going to do? There's nowhere to... what are you going to ablate? You can't ablate all of these things. What about the evolution? So ectopic atrial tachycardia can sometimes evolve into, especially in older people, it can flip into atrial fibrillation and be dangerous. Atrial flutter can also flip into, progress or evolve into atrial fibrillation as well. As I said the atria is like shaking a little cup of jello here. It's just quivering. And runs about, the atria are contracting around 550 beats per minute. Now, do you think the ratio of atrial to ventricular contraction is that fast? No, thank goodness it's not a 1-to-1 ratio, because your ventricles would explode at 550 beats per minute. They'd seize up and no blood would come out of the heart. Thank goodness for that AV node, right? How about some associations? Myocardial infarction is the most common form of atrial arrhythmia or atrial tachycardia seen in patients either right before the myocardial infarction or as it's going on or right after it occurs. In patients greater than 65, the incidence is about 22% in myocardial patients. So about 22% of patients are going to end up with AFib after myocardial infarction. Another cause of it, perhaps a treatable cause, is hyperthyroidism. Always think of the thyroid. It can make the heart really twitchy. Status post-coronary bypass surgery, which probably means the patient had a heart attack, so it kind of loops back to this one. But there may be they nick the myocardium during the procedure, and that can form a irritable ectopic foci as that heals, or it can form a kind of a racetrack because of that scarring. How about some more associations? Hypertrophic cardiomyopathy, mitral valve disease, regurgitation, stenosis. These all make the heart twitchy. Ischemic cardiomyopathy, we already talked about, can make the heart twitchy. Right atrial enlargement, lots of associations with AFib. From an ASD, tricuspid stenosis, pulmonary hypertension. Therefore, we could add COPD in here, right? Why not? COPD, let me make a note on that. I got a lot of tidying up to do on this from this lecture. COPD. Wolff-Parkinson-White syndrome, I don't know if we're going to have time to get to that. Hopefully, we'll try to get to that on Monday. I have that on YouTube, too, if I don't get to all this stuff. Also common in acute conditions, so you got to worry about pulmonary embolism can kick someone into AFib, or peracute pericarditis can kick someone into AFib, so you got to work those conditions up. How about some other associations? Sleep apnea. We're learning more and more about sleep apnea. Causes all sorts of problems, but it can make the heart twitchy. Holiday heart. Mr. Belushi drinking too much again, and that's a common cause. Take it from personal experience. Had a problem with this myself. So it can definitely, alcohol can definitely make the heart twitchy. Okay, I think we've gone long enough. Where are we at? Yeah, we've gone long enough. So we'll pick up on these EKG findings next time. All right, see you later.